We will start with the mouth, which is also called as buccal cavity. Okay, so anteriorly it has lips, laterally it has cheeks, and superiorly it has palate bone, and inferiorly inside the mouth you have the pharynx, the tongue. Okay, and the posterior part, when you open the mouth and you look into the mouth, you see the oropharynx area. Okay, generally this area, the whole mouth is made up of stratified squamous epithelium, that is multiple layer of squamous cells. Okay, so this is keratinized on the gums, hard palate, and dorsum of the tongue. Lips and cheek composed of skeletal muscles core. Okay, the orbicularis oris is a muscle that is present around the lips, and the buccinator forms the cheek. Okay, so generally this buccinator and masseter are called as the muscles of mastication. They help for chewing. Okay, so if you see, now we will see this mouth in this model. So if you see here, this mouth, this is called as the oral mucosa. This is called as the oral mucosa. This is called as the oral mucosa. And here I will remove the skeleton, and here, and this is the buccal cavity. Okay, what you see here inside here is the buccal cavity. These are the buccal cavity, and these mucosas are made up of this stratified squamous epithelium. So when you speak about the mouth, we have to start with the teeth. Okay, the teeth are it's a hard bony structure. So I will tell a few words about the teeth. This teeth, there is permanent teeth and deciduous teeth. Okay, so what is the difference between these two? Deciduous teeth, we call it the milk teeth. They start to grow when the baby is born, and after a few years they start to fall, and the permanent teeth start to come. Okay, so I would like to show you one picture that shows the various age growth of the teeth. Based on this, also we can know the age of the patient. Okay, age of the. In this picture, what you see here is the picture of dental arrangement. Okay, so anterior two, we call it as incisor teeth. Then the incisor teeth, okay, we divide this into half. Okay, we discuss only one side, upper jaw. Okay, this is two incisors are present, one canine is present, and two premolar is present, and three molar teeth are present. Okay, whereas in the newborn, the teeth that start to grow is there only two incisors are present, one canine and only two molars. Okay, the third molar and two premolars are absent. This will fall down, and as the person grows, this will start to grow. Here you can see this is a milk teeth, that's a deciduous teeth. Okay, there is two molars, one canine, and two incisors in the right jaw and the left, right side and the left side. Okay, this is the dental formula you have to understand. This is a dental formula you have to understand. Okay, structure of the teeth. The outermost hard part is called as the enamel. Inside this you have the dentine. But when you remove the dentine part, there is a cavity which is called as a pulp. Okay, so this is the root of the teeth. And this is the dental ligament. We call it as a cementum, that is inserted in the jaw like a peg in the hole, and through which the branches of the trigeminal nerve passes inside and innervates. So these are very highly sensitive nerves, and when it is irritated by dental caries, it creates huge amount of pain. Picture, if you see, at the 9th month, the central incisor teeth comes and it falls at 7 years. Okay, likewise the lateral incisor comes at 12th month and falls at 8 years. Then canine teeth comes in 18th month and falls by 11 years. First molar comes by 15th month and falls by 10 years. Okay, then second molar comes by 26th month and falls by 10 years. Okay, so this is how the age growth that is present, I mean growth of the teeth according to the age in the children's. Okay, whereas after this falls down, after these teeth fall down, the permanent teeth start to come. So don't damage the permanent teeth. Okay, that's very important. Picture, if you look at the adult teeth growth age, the those old teeth are fallen and it is replaced by the permanent teeth. So these are the permanent teeth. Okay, so the central incisor, as I told you, it comes by 7.5 years. Lateral incisor comes by 8.5 years. Then canine teeth comes by 11 years. Then first second premolar comes by 10 and 11 years, and first second molar teeth comes by 6 and 12 years. Third molar comes by 17 to 21 years. When this third molar teeth growth is present, the growth is finalized. Even the bone also will not grow. And when this last molar teeth comes by 17 to 22 years. So when the molar tooth, third molar tooth erupts in your mouth, that is the final age growth, I mean growth age. Okay, so when you attain full growth, the third molar will be present. Okay, so this is how the dental growth pattern you have to understand according to this. So if there is a dead body, by counting at the teeth, we can say this is the age of this patient, dead person, like that. Okay, so by counting the teeth according to this age, so this chart plays an you can understand the important age level according to the dental growth. Okay, so let's go back to the model. This is the incisor, this is upper jaw that is formed by the two mandible bone, maxilla bone, and lower jaw it's formed by one mandible bone. It is formed by one mandible bone. Okay, so I will remove this gum, we call it as gingiva. Okay, if there is any inflammation in the gingiva, we call it as gingivitis, which is usually common in the vitamin B12 deficiency. So what we do, we divide the face into right side and the left side. Okay, we pick only one mandible. If you see the mandible, these are all the holes where the tooth sockets are inserted. Okay, so likewise, if you see the maxilla, these are all the tooth socket that is inserted. Okay, we call it as gomphosis joint, where the tooth is just inserted in the peg. Okay, so I will remove this gum. So now what you see, as I told you, I will divide this into half. This is the central incisors and the lateral incisors. So I will remove this central incisor and lateral incisor. Okay, now this is a canine teeth. So this canine teeth is very long and sharp for flesh eating animals, for example tiger, then fox. Okay, if you see, they are very long and sharp to bite the flesh and tear it off. Okay, so that's why it's called as canine teeth. This is also just inserted into the bone. Okay, maxilla bone. Okay, next you have two premolar. This is first premolar and the second premolar. Okay, so this premolar teeth also has only two root, whereas the second premolar root, it has only one root. Okay, so this is the premolar tooth, two premolar, and there are three molar teeth. These are the main teeth for grinding. Okay, so these molar teeth are innervated by the branches of the trigeminal nerve. How I will show you, you can see here, I will place all the nerves here. Okay, here if you see, you can see these are the branches of the trigeminal nerve. Okay, you see the trigeminal nerve will come and enter into the dental socket here, and it supplies the nerve. So if there is any dental caries, it goes and irritates this nerve root, and it causes severe amount of pain. So dental caries, we call it as dental caries, which is called as a decayed tooth. So these are all the tooth pattern you have to understand. These are all the tooth pattern you have to understand. Okay, you need to understand about this tooth pattern. So coming to this mouth, this is the mouth, the maxilla bone. Here the posterior extension is the hard palate, and it is continued as a membrane like structure that is called as the soft palate. Okay, and this is a buccal cavity, and you have the location of the tongue here. Okay, so this under the base of the tongue you have the mylohyoid muscle. You have the mylo. So in this we will see this the face architecture. So if you see the muscle underneath, this is the mylohyoid muscle. This is a mylohyoid muscle. On this only you have the tongue is sitting on the mylohyoid muscle. Tongue is sitting on the mylohyoid muscle. You can see the tongue. You can see the tongue and the mylohyoid muscle. You see, this is the arrangement of the muscle under the tongue. Okay, so now if you see here, let's go into the buccal cavity. So I will hide this. Okay, I have hidden this. This is the tongue. So now I will explain the tongue. Okay, tongue is very special organ, very dangerous organ also, because we speak unnecessary thing with the tongue, and okay, so if you look at this tongue, I will remove the skull. Okay, now what you see here is the tongue. So this tongue is responsible. It has lot of taste buds. Okay, so the tongue muscle is called as hyoglossus muscle, and in the anterior aspect of the tongue, you have this fulliform and fungiform papillae. You can see there are a lot of small dots on the tongue. Okay, that's called as fulliform and fungiform papillae, and this is the circumvallate papillae. You can see this is the circumvallate papillae. And these are the lingual tonsils. These are the lingual tonsils. If you see in the post aspect of the tongue, you can see these areas. These are the lingual tonsils. Okay, so these are the taste buds that detect the sense of taste. Okay, the anterior 2/3 of the tongue is innervated by the facial nerve. Okay, that is also very important clinically, but I don't know to what level you have to learn, you need to learn anyway. So that is the tongue. Okay, so now we will go into the remaining part. So this hard palate is extending as a soft palate, and there is a extension called uvula. Okay, this is also a lymphatic tissue. This is also made up of lymphatic tissue, and when you lift the tongue, this membrane is called as a frenulum. So some newborn child, congenitally this is small, so we call it as tongue tie. The children will not be able to speak. Okay, this is the frenulum. Okay, now let us go into the salivary glands after this. So chewing is mastication. The process of chewing is called as mastication. When you chew, the saliva is secreted, and that saliva is mixed with the food, and we call that substance as bolus. Okay, so we swallow the bolus. So now coming to the salivary secretions, it is done by the autonomic control system. Okay, whenever you see delicious food, more salivation starts. You have more amount of salivation. In previous lecture I have told you, in 24 hours around 1500 ml of saliva is secreted. Okay, it consists of water, mucus. Okay, so then palate I have shown you, tongue I have shown you. These are the fulliform and fungiform papillae. This is the circumvallate papillae, and these are the lingual tonsils. Okay, so in the side of the palatal arch you have the tonsil gland. Okay, so this tonsil gland is lymphatic. In lymphatic system I have explained about this tonsils gland and how the enlargement causes difficulties. Okay, so This is the different parts of the tongue. So saliva cleans the mouth, dissolves food chemicals, moisten food and help compact into bolus. This saliva contains one enzyme called tyalin, okay, that is secreted by the parotid gland, the tyalin. So this will convert carbohydrate into glucose in the mouth. So that's why whenever immediately when you put the food in the mouth, you get some energy. That's why immediately when you put the food in the mouth, you get some energy. So let's see about salivary glands. There are three pairs of salivary glands: parotid, submandibular, and sublingual. Okay, I am going to show you that gland. Okay, so now if you see, this parotid gland will secrete a serous type of fluid, and the submandibular gland will also secrete serous type of fluid. Sublingual gland will secrete only mucus type of fluid. Okay, so let's go into the parotid gland. This parotid gland is exactly located on the cheek. Okay, this is the parotid gland. This secretes an enzyme called tyalin. Okay, Ptyalin. So this parotid gland, it is present exactly in the, if you look at the ear pinna, this is the ear pinna. Just below that you have the location of the parotid gland. So what happens during mumps? Mumps is a viral infection that leads to swelling of the parotid gland. Okay, mumps, you take vaccine for this, MMR, measles, mumps, rubella vaccine. Okay, so mumps is the gland that is, this whole parotid gland is covered by the investing layer of the cervical fascia. So this parotid gland is a exocrine gland, salivary gland, that gives a tube-like structure, that this tube opens in the side of the buccal cavity. This tube is called as Stenson's duct, also called as a parotid gland duct. Okay, in the entrance exam they will ask you this kind of questions when you are going for higher education. Okay, so this is opening in the side of the cheek. Okay, so that is the parotid gland duct. The important part, surgically, this parotid gland is having lot of surgical importance because the facial artery is coming through the parotid gland. Okay, the facial artery is, this is the transfacial artery. This is coming through the parotid gland tissue, and especially the facial nerve is passing through this parotid gland. You see, this is the facial nerve. This is the facial nerve. Okay, this is the facial nerve. The branches of the facial nerve divides inside this parotid gland. Okay, so whenever there are chances of stone formation, we call it as caliolithiasis. Caliolithiasis means stone in the parotid gland duct. Okay, I will show you. Sometimes you will wonder, oh, this kind of diseases are present in the human body. Okay, this is the parotid gland duct stone. See, this is caliolithiasis means stone in the this is not parotid gland duct stone, it is a sublingual gland duct. You see, this is the size of the stone, it is removed from here. Okay, so this size of even 1 centimeter stone can grow in the salivary gland. Okay, that condition is called as caliolithiasis. Okay, this is the condition you have to understand. This is present in the cheek. And now the next gland is submandibular gland. Just under the ramus of the mandible, if you place your finger, you have the submandibular gland. Okay, this is a submandibular gland. This is also secreting serous fluid. You see how much, see the location of the gland. This gland is opening by the side of the tongue. We call it as a frenulum. So what I will do, I will hide this. I will remove the nerves, it will confuse you, and also the arteries. Okay, you see, this is the submandibular gland duct. It's called a Watson's duct. Okay, that is opening by the side of the tongue. Okay, so when you lift the tongue and see this frenulum, by the side you have opening. That is the opening of the submandibular gland. Okay, then the third gland is the sublingual. Just by the side of the tongue, you see there are some 13 to 14 submandibular ducts. This is called as duct of Bevinus. This is called as duct of Bevinus. This is also opening by the side of the tongue. This is also opening by the side of the tongue. So these are the three glands: the parotid gland, submandibular gland, and the sublingual gland. These are the three glands that is present in the buccal cavity, okay, that is present in the face. Okay, so these three glands secretes around 1500 ml of saliva in 24 hours. Okay, so saliva's composition, if you see, it has 97% water and the pH is 6.75 to 7, almost neutral. Okay, it has glycoproteins, then electrolytes are present. Salivary amylase, this is what I was telling about the tyalin enzyme. Okay, that's called as salivary amylase, PTYALIN. Okay, and lysozymes are present in saliva for antibacterial activity, and defensins for antimicrobial protein, and also nitrogenous waste. Okay, these are the composition of the saliva. You can see, as I told you, parotid gland. This is the parotid gland duct, also called as Stensen's duct. So then submandibular gland, that's called as the submandibular duct, also called the Watson's duct, and sublingual gland, that's also has a duct called as the duct of Bevinus. Okay, so these are the then coming to the pharynx. I have explained many things about the pharynx and respiratory system also. Pharynx is divided into nasopharynx, this green one, yellow area is oropharynx, and the gray area is the laryngopharynx. Okay, so this oropharynx is a common passageway for air as well as food. Okay, so the main function is to send the food to the esophagus. Okay, now esophagus. Okay, esophagus is a 25 centimeter long tube like structure, okay, which pierces the diaphragm and joins the stomach in the cardiac end. This is a cardiac end. This is a cardiac end. Okay, it's also called gastroesophageal sphincter. Okay, it has it has all four basic alimentary canal layers. Okay, outer adventitia layer, middle muscular, and inner mucous layer. Okay, so this is the cross section of the esophagus: outer adventitia, then submucous layer, and the muscular layer. And the muscular layer, the epithelium is the stratified columnar epithelium in the lower end of the esophagus, whereas in the upper end it is stratified squamous epithelium. Okay, so I will show the esophagus here. As I told you, this esophagus starts in the laryngopharynx. Okay, this is the esophagus. Okay, and this is 25 centimeter. It has three parts: cervical part. It has three part, that is cervical part, thoracic part, as well as the abdomen. I have to remove this liver for you. Okay, this is the abdominal part. Okay, so this abdominal part only, they come and pierce the diaphragm. They come and pierce the diaphragm. If you see the muscle here, you see this esophagus is piercing the diaphragm. Okay, this esophagus is piercing the diaphragm here, and it is coming into the abdomen. Okay, so if you look at this esophagus, this junction is called as a gastroesophageal junction. Gastro means stomach, esophageal means esophagus. This junction is called as gastroesophageal junction. It has one circular muscle that is called as a cardiac sphincter. This circular muscle is called as a cardiac sphincter. Okay, so there are many pathologies we can explain about the esophagus. Okay, tracheoesophageal fistula, then esophageal atresia, or cat skewering, then Barrett's esophagus. Many diseases we can discuss about the esophagus. Okay, so then reflux esophagitis, that is acid in the stomach will burn the esophagus. Okay, sometimes you get regurgitation, you feel the chest burning sensation. Okay, so let's go with the PowerPoint. Okay, So if you look at the digestive process from mouth to esophagus, mouth will ingest the food, begins mechanical breakdown. That is, teeth are breaking the food into small substance. The food is broken to 25% in the mouth, remaining 75% is broken by the breaking. 75% of breaking the food substance is taking place in the stomach. Okay, so starts a chemical breakdown. Mastication means it is a chewing process. Okay, deglutition means it is swallowing process. Deglutition means it is a swallowing process. You see, this is a bowl. When it is mixed with saliva, it is called as a bolus. So when you swallow the food, what happens? This when you are chewing, the esophagus is closed. When you swallow, what happens? This epiglottis here, it is open straight here. When you are swallowing, this epiglottis comes and closes the respiratory passage, and then you stop breathing and you swallow. That time the food goes in the esophagus. This is important. So this closing of the epiglottis is a conscious function. Okay, so that's why when you are people say don't talk or don't lose your concentration when you eat. So what happens when you are careless? What happens? The epiglottis will forget to close and the food will go into the respiratory passage and you will start to cough. That's why you should not speak when you eat the food. Okay, so that is very impossible with you people. I know that. But this is the physiology that is taking place when you are swallowing the food. Okay, so this is called as a bolus. Okay, that is going into the stomach. So as I told you yesterday, I have shown you the previous lecture I have shown you the stomach contraction. I have shown you the stomach contraction, peristaltic movements, that is propelling the food towards the stomach. This gastroesophageal sphincter always remains closed. When the food comes here, the sphincter opens and food goes into the stomach and it closes. If there is weak circular muscles, then the stomach will go and hide in the thoracic cage. That's called as hiatus hernia or diaphragmatic hernia. Okay, I will show you a picture of that. So here is, due to weakness of the diaphragm muscles, the stomach escapes into the thoracic cage, so part of the stomach. So that's called a hiatus hernia. Or when a person is coughing, the intra-abdominal pressure will increase, then also the stomach can prolapse into the thoracic cage. So this is called as a diaphragmatic or hiatus hernia. Okay, here you can see them. There are grade 1, 2, 3, 4. Grade 1 and grade 2 no problem. Grade 3 and grade 4, what happens? Maximum part of the stomach goes to the intestine and causes severe discomfort. Then the patient needs surgical intervention. Okay, so this is what you have to know about the gastroesophageal junction. So coming to the stomach is actually a J-shaped structure which has a greater curvature and lesser curvature. It has cardiac area, fundus area, body and trunk. Okay, the pylorus is the junction that is connecting the stomach to the duodenum. The pylorus is the junction that is. So if you look at the physiology of stomach, it's very distinct. Let me show the stomach and explain in the model. So you see, this curvature is called as lesser curvature. This curvature is called as a greater curvature. Okay, this curvature is called as a lesser curvature, and this curvature is called as a greater curvature. If you look at the layers of the stomach, you have the mucus layer. That mucus is special, we will discuss in the slide. And you can see lot of folds. You see this kind of folds. This fold is called as a rugae. Okay, so this rugae will stretch when you put more food into the stomach. Understand? And the stomach mucosa is special because even though if you put the finger in 1 pH acid, your finger will melt, but your stomach is not melting because daily the stomach is fighting with the acid to save from the acid. In simple terms, you can say the stomach mucosa is fighting with the acid to save himself. Please, some stomach says don't eat me. So for that, the stomach will produce strong mucus barrier, okay, so that the acid in the stomach will not burn. But the food that you swallow, like meat, bone, all these things melt. Okay, Then you have the muscular layer of the stomach. You have 3 layers of muscle, that is the inner oblique layer, then middle circular layer, and the outer longitudinal layer. These are the 3 muscle layers. Whereas in the esophagus you have only the circular and the longitudinal muscle. This oblique layer is absent. Okay, so because of presence of these 3 layers, stomach is able to stretch. Some people will eat 2 to 3 plates of food. Okay, so all those foods are getting accumulated in the stomach. The stomach is stretching because the presence of 3 layers of muscle. The stretching property is more. So during stretching, this rugae will stretch and it will prevent the damage of the mucus. Okay, then the outermost layer is this serosa layer. Okay, but whereas in the esophagus it is adventitia layer, whereas in the stomach, inside the peritoneum, we call it as outer layer as serosa. Okay, so the blood supply to this lesser curvature is different, greater curvature is different. That is very important. You see, for lesser curvature, the blood supply is by lesser gastric artery, whereas for greater curvature, the blood supply is for gastromental artery, and also this one. Okay, wait, this one. This is a short gastric arteries. Okay, so 2 different route of blood supply is present for the stomach. Okay, 2 different route of blood supply is present for the stomach. Okay, so this is the cardiac part, this is a fundus part, and this is a body, and this is the pyloric part, and this is antrum. This area is antrum. Okay, so when you put endoscopy into the stomach and see ulcer in the antrum, ulcer in the fundus, ulcer in the body, ulcer in the pyloric junction, like that you have to mention. So this is cardiac part, fundus part, body part. Generally we mark a line here. Okay, fundus, body, and the antrum. Okay, so this dotted line junction is the antrum. Understand? And this is a pyloric part of the stomach. Okay, this is a pyloric part of the stomach. Okay, now if you see, so what happens, food comes and drops into the stomach, and then the hydrochloric acid, the stomach secretions start to mix with the food. Okay, stomach secretions start to mix with the food. When this secretion is mixing with the food, then it becomes a creamy paste. We call that as chyme. Okay, so that means what? The food that is coming from the stomach to the duodenum, we call that as chyme. Okay, so this is a valve like structure. This is a pyloric sphincter. Okay, it's a round circular muscle. It always remains closed. Only the water goes directly, but if it is food, it doesn't open, because food, meat, vegetables all have to mix with the hydrochloric acid and other gastric secretions, and then it has to become creamy paste. Okay, that's why the stomach is the pyloric sphincter remains closed. Okay, so let's go to the physiology of the stomach. Okay, the lining is dotted with deep gastric pits, that's called as a rugae. Surface epithelium is reforming every 3 to 6 days. The glands that is present in the stomachs are mucous neck cells, parietal cells, chief cells, which is also called as oxyntic cells, and enteroendocrine cells. These are the 4 cells that is present. Okay, so where are these cells present? See, this is the gastric pits. Okay, this is the columnar epithelium. Inside the columnar epithelium, these secreting glands, the parietal cells and the chief cells, are mixed. Okay, so these parietal cells and chief cells, they secrete these stomach secretions, gastrin, and the other. It also forms the hydrochloric acid. Okay, now let us see into the secretions secretions by these cells. Okay, as I told you, you have 3 kind of cells, that is enteroendocrine cells, chief cells and the parietal cells. These are the cells that is arranged in between the columnar epithelial cells of the stomach. So these secretions come and pour out in the stomach like this. Okay, now I want to go a little bit deep into the physiology. So mucin neck cells, this is thin acidic soluble mucus. Okay, they secrete the mucus. Chief cells, they secrete pepsinogen. They secrete mainly the pepsinogen. The parietal cells, they produce, see the word, secretion is different, production is different. They produce hydrochloric acid. Okay, that means what? How the hydrochloric acid is produced? So what happens? The hydrogen molecule will be secreted separately, chloride molecule will be released separately. When it comes to the lumen, the hydrogen and chloride meets together and mix and form the hydrochloric acid. So in fact the stomach is not directly secreting hydrochloric acid. It is not chemical factory. It is forming the hydrochloric acid in the gastric inside the stomach. Okay. Then the enteroendocrine cells which produces gastrin, and then enterochromaffin like cells which produces histamine. So the main thing is pepsinogen. That I will tell the use of pepsinogen. Okay, so here you can see in this picture, you can see the mucus cell secretes the mucus and bicarbonate. The parietal cell secretes hydrochloric acid and the intrinsic factor. Enterochromaffin cells produces histamine. Chief cells produce pepsin and gastric lipase. Okay, then D cells produce somatostatin, that is endocrine function. Then G cells produce gastrin. So here these three, this pepsin and the gastric hydrochloric acid, these two are very important. Okay, so this pepsin is necessary for protein metabolism, and the gastric acid, hydrochloric acid, is responsible for emulsification the fat. I will tell you the function. So remaining somatostatin, gastrin, all these go into the bloodstream and make the alert the duodenum. Hey duodenum, see, the more meat ball is coming, more bones are coming, so be ready. Like that they will try to alert the other organs. Okay, that's what the somatostatin functions like. Okay, so now you can see the mucosal barrier, as I told you. This mucosa is very important. When there is any break in the mucosa, the acid will start to erode the stomach. You see, these are all, that's what we call it as gastric ulcer. That's what we call it as gastric ulcer or the peptic ulcer. So what happens, you have to keep the acid diluted. For people who have gastric ulcer, that can be due to poor diet habit, or psychologically they will be nervous, or there is an organism called Helicobacter pylori. There is an organism called as Helicobacter pylori. This organism can also break the mucosal barrier and allow the acid formation. Okay, that organism, you see, it survives in 1 pH also. See, that's the speciality of Helicobacter pylori. Okay, so there are special treatment for that. So we have to rule out that the patient is having H. pylori infection. Okay, so this acid burns the stomach muscles when there is break in the mucous membrane. Okay, now let's go to the liver. So the liver secretes bile. The pancreas secretes digestive enzymes. Okay, so coming to the liver is said to be the largest exocrine gland. The liver is said to be the largest exocrine gland. Okay, so if you look at the liver, this liver is placed in the right hypochondrium. Okay, I mean right upper quadrant. Okay, it is placed in the right upper quadrant. You see, this is the costal margin. Okay, so this is a costal margin. Generally you have to put the finger here. You have to put the finger in this area and ask the patient to breathe. Okay, so generally liver under the 12th rib, if you put the finger, you can palpate the you cannot palpate the liver in general. Only when the liver is enlarged, you put the patient hand under the 12th rib and ask the patient to take deep breath. The time the tip of the liver comes and touch your finger. So this is how you examine the liver. This is how you examine the liver. Okay, this is how you have to examine the liver. So coming to the liver, liver is very interesting organ. As I told you, it is having a lot of function also. We will see that. So coming to the anatomy of the liver, it has 4 lobes. This is the right lobe, the largest one, the left lobe. Okay, then the caudate lobe and the quadrate lobe is present in the inferior surface. The caudate lobe and the quadrate lobe is present in the inferior surface. So I have turned. This is the quadrate lobe and this is the caudate lobe. Okay, so you see, this is the right lobe. The posterior aspect of the right lobe is giving one hepatocaval ligament. What is this? This right lobe is hugging the inferior vena cava. Please, you have to note this. You see, because I will tell you the clinical importance of it. This is the inferior vena cava. Okay, this is the inferior vena cava and this is the hepatocaval ligament. This is the right lobe, the largest lobe. It is just hugging the inferior vena cava. It is just hugging the inferior vena cava. And the right lobe and the left lobe is divided by a falciform ligament. Okay, this is a falciform ligament and this is the cardinal ligament. In the superior aspect, you have the cardinal ligament, or also called as coronary ligament, that is attached to the diaphragm. That's how the liver is. See, 1.5 kilo is hanging. 1.5 kilo is hanging on the, with the attachment of this coronary ligament to the diaphragm. Okay, imagine if you drop your mobile phone, it just drops, isn't it? So whenever in road traffic accident, what happens when the person is just thrown out? What happens? This full 1.5 kilo liver will just tear this coronary ligament and come down. Thereby it will be damaging the blood vessels that is connected to the liver and the inferior vena cava. So that's why the patient dies with the abdominal bleeding. That's why the patient dies with the abdominal ligament. This falciform ligaments extends as a round ligament. This round ligament is nothing but the remnant of the fetal circulation. Okay, the umbilical artery and the umbilical vein comes through this and joins the inferior vena cava. So this round ligament is nothing but remnant of this fetal circulation. Okay, so these are the 4 lobes of the liver. You have know it is also having lot of microscopic importance. Okay, so underneath, if you see, this junction is called as the porta hepatis, through which the common hepatic duct is coming out. Then the portal vein will go inside. The portal vein will go inside and the hepatic artery is also going. So this is the hepatic artery. This is the right and the left hepatic artery is going. Then also the portal vein. Okay, also the portal vein. You see, this is the portal vein. Okay, so this junction is called as the porta hepatis. Okay, you see, you can see clearly visible here. Hepatic duct, common hepatic duct is coming out from the liver, bringing bile juice, and this is a portal vein that is taking the blood from all over the intestine. That is taking the blood from all the intestine towards the liver, and this is a hepatic artery that is taking the arterial blood. It's a branch of celiac artery. It's a branch of, this is a celiac artery. It is a branch of hepatic artery that is going inside the liver. Okay, so this junction is called as the porta hepatis. And if there is narrowing of this junction, what happens? The venous blood from the intestine doesn't go to the liver. Okay, So when generally the portal vein pressure will be 13 by 7 millimeter of mercury. That's normal portal vein pressure. I told veins don't have pressure, but this portal vein, it has pressure. Okay, if there is block here and the portal vein pressure increases, then it leads to vomiting sensation in the patient, and sometimes the superficial blood vessels in the GE junction will rupture, and that leads to severe amount of bleeding. This takes place in the people who are suffering with hepatitis viral infection. That's pathology is a different mechanism. Just know the importance of porta hepatis. Just know the importance of porta hepatis. Okay, so coming here, this is the we have seen. Coming to the liver, the liver is an accessory organ of digestive system, which is around 1.5 or 1.4 kilo, which is present in the right hypochondriac region. It is composed of right lobe, left lobe, caudate lobe, and the quadrate lobe. The main role is production. There are many different functions for the liver, but the main function is production of bile. I'll tell you what is the function of bile. So coming to the gallbladder is a cystic pouch that is acting as a temporary reservoir, of blood. Okay, so if you see here, this is the common hepatic duct. Okay, and here it takes the name as common bile duct. Okay, there is a perpendicular connection. This is called as cystic duct. This cystic duct, it ends as a pouch that is called as a gallbladder. So if you look at this gallbladder function is to store the bile juice. Come here, and then the bile juice has to mix with the food in the duodenum only when the food comes in. So that time what happens, this bile juice will go and store in this gallbladder. So the role of gallbladder is to increase, it will absorb the water molecule and increase the concentration of the bile. Okay, and increase the concentration of the bile. Under the liver, if you see, this pit is called as a gallbladder fossa. This pit is called as a gallbladder fossa, where the gallbladder is placed. Okay, so sometimes more absorption of water leads to sludge formation of the bile that cause severe pain here, the right hypochondriac region. Then gallstone, we call it as cholelithiasis. Stone formation is common in the gallbladder. This stone will come back here and it can block this bile duct. Okay, so this is the hepatobiliary tree. This is called as a hepatobiliary tree. I will show you how the tree is. I will remove the liver. You can see these are the tree. This is coming from the left hepatic duct, and this is the right hepatic duct, comes and joins to form the common hepatic duct. So this common hepatic duct goes straight as a common bile duct. Okay, but there is a perpendicular connection, that's the cystic duct and the gallbladder, where the biles comes and stores here, increase the concentration and temporarily stays. So once the stomach opens and releases the food into the duodenum, then this gallbladder will go in for constriction, and the bile juice will come and rush into the this bile duct and goes into the duodenum Okay, this is what you have to understand in the hepatobiliary tree. Okay, hepatobiliary tree. Okay, so now if you see here, okay, coming to inferior aspect, this is a porta hepatis, where you have the hepatic artery, portal vein, and the common bile duct is present, and this is the junction where the inferior vena cava is passing. Okay, this is the caudate lobe. This is the gallbladder. Which has a gallbladder fossa. Okay, so you also have the scene. So now liver and the gallbladder. So bile is a yellowish green alkaline solution. So stomach has acidic food. So this alkali mixed with the acid, it neutralizes the acid. Okay, so it contains bile salts, bile pigments, cholesterol, phospholipid, and variety of electrolytes. Okay, bile salts will help in the fat metabolism. Bile pigment what is bile pigment? It has a long thing to discuss. Okay, bile pigment is the pigment which adds yellow color to your fecal matter. Okay, you eat green color food, white color food, brown color food, but the fecal matter is always yellow in color. That is because the bile pigment will mix with the food and changes the color into yellow color. Okay, and also the liver is secreting two type of salt, sodium taurocholate and sodium glycocholate. This gives bad smell to your fecal matter. Okay, sodium taurocholate and sodium glycocholate. So if how the liver gets bile pigment, as I told you, this is done by the reticuloendothelial system. The RBC cell lives for 120 days, which has hemoglobin. After 120 days, the RBC cells are crushed and the hemoglobin is taken out. That hemoglobin is divided into heme and globin. Globin will be circulating in the blood. Heme will be changed into bile pigment. Okay, and that bile pigment is filtered in the liver. Okay, so if the liver is not, if the hepatic duct is blocked, what happens? The bile pigment stays in the blood and eye mucosa becomes yellow in color. That's what we call it as jaundice. Okay, then the gallbladder, as I told you, it is storing the bile juice and it is increasing the concentration. The bile mainly emulsifies the fat and breaks down the fat into smaller substance. Okay, it has main role in the fat metabolism. You see, the fat molecule is coming to duodenum, so these bile salts will go and cover the fat molecule. This process is called emulsification. So by this, the fat is easily converted into fatty acid. There is another mechanism, I'll tell you, metabolism of fat, you will understand. So then the intestine will absorb the fat as fatty acid and send into the Peyer's patches. This is the lymphatic duct tube. Okay, so coming to the microscopic anatomy of the liver. So this microscopic anatomy, I will continue now. Wait.